Dr. Gigi Augustine to please come forward and present her talk on guidelines in the management of ESO deviations. Over to you, Dr. Gigi.
First of all, let me thank Dr. Elizabeth and KSOS for giving me an opportunity to present this topic here today. I'll be discussing about general guidelines in the management of esotropia. It's a vast topic, so I'll just rush through and discuss about the general guidelines. So, as you all know, the sensory adaptation in a case of squint is not the same for children and adults. Children can have abnormal sensory adaptation during the critical age group, especially amblyopia and absence of stereopsis. So the goal of the treatment is not just to provide cosmetic and 6/6 and 6 vision, but to provide best stereopsis possible. So this is Dr. von Noden's classification. And a proper systematic workup is required to arrive at a diagnosis and manage. First of all, observe the patient and don't miss any abnormal head posture. Take a proper history. And examination of eyes include, start with age-appropriate visual acuity assessment, anterior segment evaluation to rule out any organic pathology, and age-appropriate cycloplegic refraction and full hypermetropic correction with the glasses. And atropine 1% is used for cycloplegia in children less than 5 years. Cycloplegic refraction has to be done to rule out organic pathology of the posterior segment and look for torsion and fixation pattern. Coming to evaluation of strabismus, first rule out pseudosquint. Pseudosquint is eliminated, we confirm the pseudosquint by cover and cover test because there won't be any movement. Sometimes a pseudosquint may be, it's both pseudo and true squint may be present. So you can check the Herzberg test and cover test for fixation preference. And ocular movements, versions in all gazes and ductions also. Rule out any oblique overaction or underaction and any pattern deviation. Measurement of deviation can be done with the prism cover test, both for near distance and far distance, at least in up gaze, primary gaze, and down gaze. And also assess the BSV and stereopsis. In the case of concomitant squint, look for primary and secondary deviation. A forced duction test has to be done to differentiate paralytic from restricted squint. Coming to the management options, if there is any cause, treat that first. And the treatment includes non-surgical and surgical methods. Non-surgical includes a full cycloplegic refraction and optical correction with the refraction of the refraction, amblyopia treatment, orthooptic assessment exercises, botulinum injection, prisms. These are all the treatment options available. Surgery, muscle weakening, especially MR, and muscle strengthening, LR. So amblyopia treatment, occlusion treatment is the mainstay. There is full-time and part-time occlusion. While doing full-time occlusion, beware of occlusion amblyopia. It is said that 120 occlusion hours can improve one line in the logMAR chart. Another alternative is atropine penalization. In the case of anisometropic amblyopia, we can try active vision exercises, both uniocular and binocular video games. Now coming to the accommodative esotropia, there can be after giving the full correction, there can be 3 options. First is the refractive accommodative esotropia. Here the child presents with esotropia, and after the cycloplegic refraction, there will be hypermetropia, and we give full correction. And the patient will be orthotropic for distance and near. So that's a refractive accommodative esotropia. The second case is the non-refractive type with accommodative element, that is, there will be a near distance disparity. So we had to measure AC by ratio and with a gradient method preferably, and NPA, that is near point of accommodation, with an RAF rule. So in the case of near distance disparity, there are two types, that is hyper-accommodative with high AC by A ratio, and hypo-accommodative with normal AC by A ratio and far NPA. So this is a child with NPA, that is a near distance disparity and with high AC by A ratio. So through the upper segment, so we have given executive bifocals, and when the patient looks at the distance targets through the upper segment, the patient is orthophoric. But if when the patient looks through the distance segment at a near object, there is a residual esotropia. But that esotropia gets corrected when she looks through the lower segment, near segment. So that is hyperaccommodative esotropia. And even with the correction, the third scenario is even with the correction, there is residual esotropia for both distance and near, and there is no distance near disparity. So treatment in that condition, you have to correct the accommodative element, accommodative part of the esotropia with glasses, and surgery has to be done only for the non-accommodative part. And counsel the parents about the need of wearing glasses even after the surgery. So if you see an infant with a large angle esotropia, what all could be the DDs? One is the concomitant, under the concomitant category comes the essential infantile esotropia, accommodative esotropia, and nystagmus blockade syndrome. And concomitant, it could be a sixth nerve palsy or a Duane's retraction syndrome, type 1. So infantile esotropia, usually it's not that rare. It happens, it occurs less than 6 months. Large angle esotropia, chances of amblyopia is more, that's why it is important. So no, there won't be significant refractive error or neurological deficit. There will be apparent restriction of the abduction with cross fixation. So in that case, we have to reveal that there is a full abduction by covering the other eye. You can also do doll's eye movement and check that. Associations, nystagmus, inferior oblique overaction, DVD, monocular nasotemporal asymmetry for pursuit movements can happen. Coming to the treatment, first of all, if there is a amblyopia, treat that with occlusion treatment. The endpoint is free alteration. Even if there is no amblyopia, we can do an alternate occlusion 2 hours per day to prevent MR contracture and improve the abduction. The mainstay of the treatment is surgery. So you can try a botulinum injection to the MR to delay the surgery if you can't do the surgery in early cases. So when to do the surgery? The current concept is that early surgery has advantages, and the eye should attain a stable alignment within 2 years of life. So about the stereopsis, it is said that if stable alignment is achieved by 12 months, there can be good stereopsis. And if the stable alignment is not achieved by even 24 months, the chances of fine stereopsis is nil. Not only that, if early surgery can improve the general motor skills of the child. You can consider delaying in surgery in children with CVI. And surgery, if there is alternating esotropia, you can try symmetrical bimedial recession. And if in case of severe amblyopia, you can try monocular RR surgery. And another thing is that follow-up is very important. Patient should be followed till visual maturity, and even after that, and look for amblyopia or any overcorrection or undercorrection or secondary deviations. So we have to treat it accordingly. The next one is DDS and nystagmus blockade syndrome. It is manifest congenital nystagmus dampened by convergence. That will be dealt by another speaker. And the treatment is large recession of medial rectus along with Fardens. And this also will be, that is acute acquired concomitant esotropia will be dealt by another speaker. Sometimes the child may present with, this is another scenario, the child presents with sudden onset of blurring of vision, and there will be variable large angle esotropia, and the refraction shows high myopia, but on cycloplegic refraction, there won't be significant myopia. So that is a pseudomyopia. You have to rule out any organic pathology by imaging. Treatment is conservative with atropine 1%. And also bifocals for near vision. And under the category of incomitant comes the 6-nerve palsy, left eye. In this case it is left eye. So what happens is that there is abduction restriction and FDT is negative. Treatment option is surgery. This patient requires imaging. This is a Duane's type 1 with bilateral abduction deficit. In this case, the FDT will be positive, treatment will be surgery. The key point is you can see abnormal changes in the palpebral fissure width. So the take-home message is the causes and management of esotropia is different in children and adults. Age-appropriate cycloplegic refraction is a must. Ocular examination should be done to rule out organic causes, especially like retinoblastoma. And in case of concomitant esotropia, rule out neurological problems. Correct the accommodative element if there is any. And prevent and treat amblyopia. The timing of the surgery is important, especially in essential infantile esotropia. Thank you.
Thank you, Dr. Gigi, for the one.